Okay, we can go live now and start. Over to you, Parul.
Thank you so much, sir. Good evening, everyone. Good evening, respected President, sir, Honorable Secretary, sir, distinguished guests from Saarc countries, esteemed faculty, and dear delegates. I, Dr. Parul Jindal, pediatric anesthetist, along with my colleague, Dr. Neha Sinha, pain intensivist from Republic of India, welcome all of you to this special edition of the Continuous Professional Development Program organized by the South Asian Association for Regional Cooperation, Association of Anesthetists, which was founded in the year 1991 with the support and guidance of WFSA and the vision of the founders, which was based on ancient links, contemporary needs, and the future potential that exist among these Saarc countries. This webinar is designed to share the common problems or challenges in our profession and to encourage and share the knowledge and expertise under one roof, which is the primary objective of Saarc AA in bringing all the anesthetists from 8 countries. The important landmark today is that we have completed our first cycle of the webinar with 8 constant countries: India, Bhutan, Pakistan, Bangladesh, Afghanistan, Maldives, Nepal, and Sri Lanka. We are pleased to have Bhutan on board with us today and extremely proud of all the active participants from Afghanistan who have participated in Saarc Continuous Professional Development Program. May I now invite our Honorable Secretary Sir to address the August gathering. Dr. Naveen Malhotra Sir is Director of our Pain Management Center, Rohtak, Haryana. He is former Senior Professor and Head of the Department Pain Management Center, PGIMS Rohtak. Sir has received Bhopal Award for Academic Excellence in 2015 and he is the KPR Young Anesthetist National Award in 2009. Sir is also President of Research Society of Anesthesiology and Clinical Pharmacology. He is the Chief Advisor of the 17th ISACON 2023 Gurgaon, Honorary Secretary of ISA National from 2018 to 2022. He is the Honorary Secretary for Saarc AA 2022-24. Sir is Deputy Chair of Asian Australian Regional Section, WFSA, and member of the ICCM Committee of WFSA. I welcome you, sir, and I request you to kindly address the August gathering.
Thank you, Dr. Parul, for that kind introduction. And I welcome all the delegates from the Saarc countries to this Saarc Continuous Professional Development Program. And today is an important landmark day because today we are completing our first cycle of participation of all the 8 Saarc countries in the online Continuous Professional Development Program. I'm very happy that finally we have representatives from Bhutan presenting their academic and clinical work at this platform, and the ever active delegates from Afghanistan presenting their clinical work. And 2 very important topics will be discussed today: post-operative nausea, vomiting, and role of regional anesthesia in management of acute trauma. And I'm very sure that the delegates will have a good time understanding each other, the geopolitical issues, as well as the clinical issues pertaining to the management of patients coming for different types of surgery, especially the anesthetic considerations. Saarc AA is a platform where we exchange our clinical and academic views, interact with each other, and definitely these online programs have brought us very, very close to each other. Next in line is Saarc YuvaCon, which will be held very shortly, and definitely we shall be meeting physically in December in Dhaka for the Saarc conference. I'm very sure today the delegates will have a very good time, both clinically as well as academically. Thank you very much.
Thank you so much, sir, for your kind words. It's my now privilege and honor to invite our President, Dr. Venkatagiri, sir. Dr. Venkatagiri, sir, is President of Saarc, past President ISA, and past President OMAG. He's Senior Consultant of United Medical Center, Kerwell Hospital, Kasargoda. Sir was our past President and GC member ISA National, past President and Secretary ISA Kerala, past President and Secretary ISA Kasargoda. Sir was past Joint Secretary, IMA Kerala, and past President and Secretary, IMA Kasaragod. Sir has attended more than 100 state, zonal, national, and international conferences and has given talks and chaired sessions in these conferences. Sir is co-author for ISA Coles Guideline. May I now request Sir to kindly address the August gathering.
Good evening, Secretary Naveen, the President, Secretaries and other office bearers of Saarc member countries. Today's faculties from Afghanistan and Bhutan, Dr. Ahmad Rashad, Akbari, and Dr. Tashi, and the chairperson, Dr. Nurullah, Dr. Hamidullah, and Jack Jamper, and all delegates, and my own treasurer, Dr. Virendra, past presidents. Good evening. As Naveen and Parul told, we are completing one cycle or one circle today, and we will be continuing this academic activity as conceived long back. We have taken all precautions and all measures to include all the countries and the topics which are relevant to patients in our region. Because our region is different from other Western countries and all, we have common things. So it will be an opportunity for the students also to know other countries and the consultant what is happening in other parts. Hope we will have more and more academic activities. And by the same time, our journal is getting ready. And today, the web hosting, they have already done that, started that work. Soon we will have the journal online and it will be physically also. With this, I wish all the best to each and everyone who have joined. And many, around 42 have joined here in this. And there may be many who are in the YouTube also. So thank you very much. Enjoy this CME and meet physically in Dhaka during the Saarc Congress in December. Thank you.
Thank you so much, sir. They say, if your action inspires others to dream, learn more, do more, and become more, you are a leader. We have one such leader with us today, Dr. Nurullah Aryan. He's a senior advisor at the Afghanistan Ministry of Public Health. He's the president of Afghanistan Society of Anesthesiologists, a senior consultant cardiac anesthetist, ICU intensivist, WHO senior ICU trainer, and a university lecturer. It's indeed an honor and privilege to have you with us, sir. Kindly be seated to chair the session. To ably support Sir, we have Dr. Hamidullah Siddiqui, who was the HOD at Mazar-e-Sharif Teaching and Regional Hospital until 2021. He's the Vice President of ASA. He's a Senior Consultant in Anesthesiology and Anesthesia Fellowship in Norway. Welcome, sir. We have our eminent speaker today, Dr. Ahmed Rashid Akbari. Sir has done his PGME program and he's a trainer and HOD of Anesthesia Department in French Medical Institute for Mothers and Children, Kabul. He's done MD Pediatrics, Senior Consultant in Anesthesiology, and is a responsible for Scientific Committee of Afghanistan Society of Anesthetists. I welcome you, sir, and I now invite you to share your presentation.
Okay.
While Dr. Rashid is starting his slides, there are a few points to be remembered that while the lecture is going on, please keep yourself on mute. And all the questions can be typed in the chat box, which will be taken at the end of the session by the eminent speaker and the eminent faculty. Thank you so much.
Hello, everyone. Could you see my PowerPoint slides?
Yes, sir, your slides are visible. Can we go to the first slide?
Yeah. So good evening to all. My topic is post-operative nausea and vomiting. So I will put a little bit definition. Nausea is the unpleasant sensation of the need to vomit. Vomiting is a forced expulsion of upper GI content. Post-operative nausea and vomiting are the most common and unpleasant side effects following anesthesia and surgery. Post-operative nausea and vomiting are the second most common complaint after pain. Annual post-operative nausea and vomiting related healthcare costs approach several $100 million only in USA. So the incidence of postoperative nausea vomiting, postoperative nausea in vomiting occurring during the first 24 hours of the after surgery. The incidence is around 30% in adult and 42% in children, rising to 80% in unmedicated high-risk patients. Post-discharge nausea in vomiting refers to postoperative nausea vomiting experience after discharge from the recovery room. The incidence is about 37%. Consequences of the postoperative of nausea vomitings are the patient morbidity, wound dehiscence, bleeding, pulmonary aspiration, esophageal rupture, fluid and electrolyte imbalance, decreased patient satisfaction, increased healthcare cost, prolonged stay in the post-anesthesia care unit, and delay hospital discharge, in unanticipated hospital admissions. Postoperative nausea vomiting may be triggered by various pathways through peripheral and centrally located receptors. However, the exact etiology is unknown. So neural pathways of postoperative nausea in vomitings after input arise where the chemoreceptor trigger zone, also known as the area of post-edema, the GI tract where the vagus nerve, the vestibular system, and the cerebral cortex. The chemoreceptor trigger zone is a circumventricular organ located on the dorsal surface of the medulla on the floor of the fourth ventricle. It lacks the characteristic endothelial tight junction of the blood-brain barrier, allowing communication between the CSF and blood. The vomiting central pattern generator for the vomiting and the irrigation of these input final common pathways and in integration of these input into a final common pathway and it located in the medulla. The nucleus solitarius NTS trigger vomiting by stimulating the rostral nucleus, nucleus ambiguous, ventral respiratory group of the dorsal motor nucleus of the vagus. Vomiting preceded by the characteristic autonomic changes, salivation, sweating, hypertension, tachycardia, continuous vasoconstriction, muscles to expel gastric contents. So the following receptors are involved in the postoperative nausea vomiting: histaminergic, dopaminergic, serotonergic, muscarinic, and neurokinin receptors. So in this picture, we can see the cortex, GI system, and vestibular system in which the different receptors are present, and they are stimulating the vomiting center, and finally the vomiting act will occur. For example, in cerebral cortex, sensory input due to anxiety, memory, meningeal irritation, or increased ICP will stimulate directly vomiting center, and it will cause vomiting in a patient. Or motion sickness lesion opioids may aggravate most nausea in the vestibular system. And also obstruction, stasis, and inflammation or serotonin release for the enterochromaffin cells from the GI will stimulate chemoreceptor trigger zone, and this will stimulate vomiting center, and finally it will cause the vomiting. Motor impulses that are actually transmitted from the vomiting center by, sorry for this, by the vomiting center by 5th, 7th, 9th, 10th, and 12th cranial nerves to the upper GI tract, and vagal and sympathetic nerve to the lower GI tract, and spinal nerves to the diaphragm and abdominal muscles. So pathways, nausea and vomiting may be induced through various pathways, maybe toxic material in the GI lumen, absorbed toxin, and drug stimulation of the vestibular system. So in this diagram, we can see that personality, emotion, anticipation, pain, and also they will directly stimulate the cortex and then the vomiting center, and will cause the vomiting in a patient. So here again, if we see apomorphine opioids will also stimulate chemoreceptor trigger zone, and this will cause vomiting in a patients in hypertonic in ACL. Also will cause, sorry, I have a little bit problem with my slides. I will minimize this. Now it will be okay. So now, again, if we see the vestibular system will be stimulated by movement, and then it will directly stimulate the omitting center or cerebral cortex, and this will cause postoperative omitting in patients. Here in this picture also different models were introduced by different scholars. We can see the drugs, toxin, radiation, they all enter this systemic circulation or through August NTS pathway. They will stimulate the chemoreceptor trigger zone or directly omitting center, and it will cause in patient omitting, vasoconstriction, airway secretion, tachycardia, abdominal muscle contraction, salivation, and act of the omitting will start or nausea will feel the patients. So if we see ingestion of the toxic substance to the GI will release serotonin 5-HT from the enterochromatin cells. Around 90% of serotonin is stored in the enterochromatin cell of the GI, and also indirect release of the 5-HT by the M3 beta and H3 receptors. Then vagal ending travel to the dorsal brainstem wave NTS, and the omitting act will occur. But conversely, the stimulation of GABA B 5-HT4 alpha 2 receptors in the presence of the vasoactive intestinal polypeptide and somatostatin have been proposed to reduce the release of serotonin. Drug observed toxin or drugs circulating in the blood will cause stimulation of the chemoreceptor trigger zone, and emetogenic triggers to the omitting center will occur, and then omitting reflex will activate. So in this picture, we have to see mechanism of how to explain apomorphine, a fairly selective dopaminergic D2 agonist provoke emesis. In the way droperidol D2 antagonist will reverse apomorphine emetogenic effects. It remains unclear how the chemoreceptor triggers scenes or transduces emetic stimuli, and why nausea vomiting are not the typical side effect of dopamine infusion. If movement occurs, so definitely it will stimulate receptor in the vestibular labyrinth of the inner ear. Impulses transmission wave brainstem vestibular nuclei will goes to the cerebellum, and then chemoreceptor trigger zone will be stimulated, and then finally omitting center will activated, and patient will feel nausea and vomiting. So omitting reflex occurs in the early stages of the gastric irritation or distension at the rate of 2 to 3 centimeters by second. So then contraction of the duodenum and stomach will occur, in relaxation of the gastric esophageal sphincter will occur, and finally omitting acting will be activated. So how patient will start this act? A deep breath, raising of the hyoid bone and larynx to pull the upper esophageal sphincter open, closing of the glottis to prevent vomitus flow into the lungs, and lifting of the soft palate and close the posterior nares. Strong downward contraction of the diaphragm along with the simultaneous contraction of the abdominal wall muscles. Squeeze the stomach between the diaphragm and abdominal muscle, and increase intragastric pressure in lower esophageal sphincter relaxes, and finally vomiting will occur. In this image, we can also see that how the cerebral cortex or omitting center stimulating, and then stimulate the omitting center, and omitting center coordinate reflexes through the cranial nerve 5, 7, 9, 10, and 12, and glottis will be, and finally here hypersalivation, pallor, sweet, or tachycardia will occur. Glottis will close, soft palate rises and close soft airway, and finally deep inspiration, diaphragm contracts, in gastroesophageal sphincter and fundus of the stomach will be relaxed, in abdominal muscle contraction forcefully will increase the pressure forced antiperistaltic wave, and increase pressure forced came upward from the stomach out of the mouth. So this is the process of the vomiting. So nausea, it's a conscious recognition of the subconscious excitation in an area of the medulla closely associated or a part of the vomiting center causes irritative impulses coming from the GI tract, impulses that originate in the lower brain associated with motion sickness, or impulses from the cerebral cortex to initiate vomiting. So about the post-operative nausea vomiting, we will go for the four main subjects: risk factors, strategies to reduce baseline risk, prevention, and how to treat. So independent predictors, it will be patient-related, surgery-related, or anesthesia-related. So about patient-related, most important key factors are female genders. Females are threefold at high risk: previous post-operative nausea and vomiting, or motion sickness are 2 to 3 times more in risk. Non-smokers 2 times in risk. Use of the perioperative opiates, anxiety, and also in adult, the incidence of post-operative nausea vomiting decreases as a patient age. For the pediatric patient, age increases the risk such that children older than 3 years have an increased risk of the post-operative nausea vomiting compared with children younger than 3 years. Surgery-related factors: major abdominal gynecological surgery, laparoscopy, cholecystectomy, middle ear surgery, thyroid, breast plastic surgery, neurosurgery, strabismus surgery. And also we can see here many surgeries are associated with the high incidence of the postoperative in nausea vomiting. So here we can see postoperative nausea vomiting, a laparoscopy due to gas insufflation of the abdominal pressure on the vagus nerve relays vomiting centers. Only laparoscopic gynae procedure, cholecystectomy, strabismus surgeries found to be independent predictors, and also emetogenic procedures are laparoscopies, strabismus surgery, middle ear surgeries, herniorrhaphies, tonsillectomies, adenotonsillectomy, and vulvopharyngoplasty. So disapproved risk factors, BMI and menses cycle, have no importance in the incidence of the post-operative nausea and vomiting. The use of supplemental oxygen does not reduce the incidence of the post-operative nausea and vomiting, and also gastric tube decompression has no effect on the post-operative nausea and vomiting. Anesthetic factors, for example, pre-medication decrease risk after benzodiazepine and clonidine, but the risk increase after opioids in pre-medication. Type of anesthesia, either it's general anesthesia or regional, it's also very important. Volatile anesthesia is associated with a twofold increase in risk of post-operative nausea vomiting, with risk increasing in a dose-dependent manner. No significant difference between different volatile agents. Nitrous oxide increases the relative risk of post-operative nausea vomiting by 1 to 4-fold. Dehydration increases the risk. Also, too early resumption of food and fluid also increases the risk. Intraoperative and postoperative opioid use increases the risk of postoperative nausea vomiting in a dose-dependent manner. Opioids reduce muscle tone and peristaltic activity, thereby delaying gastric emptying, inducing distension and triggering the vomiting reflex. The use of short-acting opioids like remifentanil does not decrease the incidence of postoperative nausea vomiting. And also, duration of surgery is also very important. If it is greater than 60 minutes, the risk of postoperative nausea and vomiting will be high. So in regional anesthesia, there is a low incidence recorded. Peripheral nerve block, subarachnoid nerve block, and epidural nerve block are lesser in risk than general anesthesia. In intraoperative nausea vomiting in the sub-independent predictor in the regional anesthesia are female gender, history of the motion sickness, pre-operative tachycardia, pre-operative IV opioid usage, use of the phenylephrine, epinephrine, hypotension, and high intrathecal block can cause nausea and vomiting. Risk score for the predicting post-operative nausea and vomiting. So currently, there are simplified post-operative risk scores for the adult and one simplified post-operative nausea vomiting risk score for the children. So, Coviventa post-operative nausea vomiting risk score feature 5 risk factors: female gender, non-smoking status, history of motion sickness, history of post-operative nausea vomiting, and duration of the surgery greater than 60 minutes. In case if 0, 1, 2, 3, 4, or 5 risk factor present in the incidence of the post-operative nausea vomiting will be 17, 18, 43, and 55, 44, 74, and 84% respectively. For example, three category: low risk, moderate risk, and high risk. For example, in a patient, if 0 to 2 risk factors present, so consider no prophylaxis, or a single antiemetic medication should be given before. If in patient in moderate risk, 3 or 4 risk factors present, administer 2 different classes of the antiemetic medication. In high risk patient, if 5 risk factor present, administer 3 different classes of the antiemetic medications. I feel a very popular risk score develop a simplified risk score that reduce the number of risk factor in the model from 5 to 4. Here, female gender, a history of nausea and vomiting, and motion sickness in the word number, non-smoking status, and post-operative use of the opioids. For example, here, if a patient have 0, 1, 2, 3, or 4 factors are present, so the risk of post-operative nausea vomiting will be 10, 20, 40, 60, or 80% respectively. For here also 3 groups: low risk, moderate risk, and high risk. In the same, like in previous we described, the same strategy should be taken. Post-operative POWOC score for use for the children. Here are 4 risk scores: duration of surgery greater than 30 minutes, age greater than 3 hours, trapezotomy surgery, in history of the post-operative nausea vomiting in a child, or post-operative nausea vomiting in his or his relative. Also has a when there are 1, 2, 3, or 4 risk factor present, the incidence is 9, 10, 30, 55, and 70% respectively. So only vomiting is reported due to difficulties in eliciting nausea in the young group age of group. High risk surgeries in pediatrics: trapezotomy, adenotransylcumy, hernia repair, or chidipixie, and penile surgery. Rare in children younger than 2 years, and risk increase with age greater than 3 hours. The increased vomiting incidence taper when a child reach to puberty. Strategies to reduce the baseline risk: avoidance of the GA by the use of the regional anesthesia, use of the propofol for the induction and maintenance of anesthesia, avoidance of the volatile anesthetic, minimization of the intraoperative volatile in postoperative opioids, adequate hydration. So minimization of nystigmine, now it's not most more important in children. Hypnotic doses of propofol 1 milligram by kg, or by 20 microgram by kg as an infusion in a combination with the antiemetic, significantly will reduce the incidence of postoperative nausea and vomiting. So in case if you found a patient with post-operative nausea vomiting, so rule out hypotension, hypovolemia, inadequate oxygenation, pain, hypo or hyperthermia, infection, hunger, poor oral hygiene, or upsetting smells in the vicinity of the patients. So for this, and then if we see management of the post-operative nausea vomiting, so it's a multifactorial, multi-pathways in neurotransmitters. So therefore, a multimodal approach is most effective. So pharmacological methods and non-pharmacological methods we will discuss. Prophylaxis versus treatment remain controversial. 3 classes of antiemetic drugs are used. First line: serotonin antagonist like ondansetron, corticosteroid like dexamethasone, and dopamine antagonists or dopaminergic D2 antagonist droperidol have a similar efficacy against the post-operative nausea and vomiting. Second line drugs: metoclopramide D2 antagonist, enciclazine antihistaminic, and anticholinergic scopolamine transdermal patches. So, definitely methaclopramide extrapyramidal and sedative side effects will be present in a higher doses in some patients. Also, due to cyclizine, sedation, dry mouth, visual disturbance, and urinary irritation may will occur. And in scopolamine, there are threefold increased visual disturbances due to compared with the placebo patient in different studies. So we will come to the slides of the drugs. Droperidol is a D2 antagonist. It's a butyrquinones group, 0.625 to 125 mg IV. Similar efficacy antagonists both. In nausea and vomiting, short half-life around 3 hours given at the end of surgery at lowest dose of the 0.625. So FDA put it in the back block box warning because side effects is anxiety, restlessness, akathisia, dystonia, torsades point, and it is reported haloperidol. Efficacy similar to the ondansetron cardiac arrhythmias and it reported approved only for the IM administration in 0.5 to 5 mg IM dosage is present. Histamine antagonist, diphenhydramate, H1 antagonist, and weak anticholinergic. Cyclazine and promethazine, it's also H1 antagonist and equal anticholinergic activity. So, given at the start, sedative side effects may delay recovery if given at the end of surgery. Side effects: drowsy, urinary irritation, dry mouth, blurred vision, promethazine may cause vascular necrosis. Anticholinergic scopolamine, centrally acting anticholinergic, short half-life, transdermal formulation up to 72 hours, effective for the prevention of the postoperative nausea vomiting in the first 24-hour postoperative hours applied the evening before surgery or 2 to 4 hours before the start of the surgery. Side effects: visual disturbances in papillary dilatation. Serotonin antagonist, ondansetron, first serotonin antagonist used for the chemo-induced nausea vomiting. Similar efficacy against both nausea and vomiting. Half-life is around 4 hours, more effective when given at the end of the surgery. 4 milligram is the effective dose and most effective antiemetic for the postoperative nausea vomiting. So side effects: headache, lightheadedness, dizziness, constipation, QT, prolongation, and torsades defines. Other serotonin antagonists like dolazetron, methylate, and granizetron, so it's liver converted active metabolite. Dolazetron are highly specific 5-HT3 antagonist with a plasma half-life roughly twice as long as that ondansetron dose 12.5 milligram, not recommended due to QT prolongation. High specific 5-HT3 antagonist half-life that is approximately twice as long as that ondansetron in doses 1 milligram of the granizetron. So planezitron, also the second generation long half-life of approximately 40 hours, exhibit allostatic binding to the 5-HT3 receptor with the subsequent receptor internalization as well a negative cooperative with the neurokinin receptor superior to ondansetron and postoperative nausea vomiting dose is 0.075 mg can be given at the start of surgery. Dexamethasone is a central inhibition of the NTS, but not the area postrema. Slow onset of action given at the beginning of surgery. Efficacy is similar to that of the ondansetron and droperidol. Dose is 2.5 to 5 milligram, 4 milligram of the ondansetron, 4 milligram of dexamethasone, and 1.25 milligram of droperidol have a same efficacy. So side effects: post-operative infection and increases in the blood glucose level. Dexamethasone, more recent study increasingly use the higher doses of dexa, 8 milligram IV rather than the minimum dose of 4 to 5 milligram. Dexamethasone also have dose-dependent effect on the quality of recovery. A meta-analysis evaluating the dose-dependent analytic effect of the perioperative dexa found that doses greater than 0.1 milligram by kg are an effective adjuncts in the multimodal strategies to reduce post-operative pain and opioid consumption. So methylprednisolone is also effective about 40 milligram. Neurokinin antagonist. So substance P binds to the neurokinin receptors found in the vagal afferent in the GI tract. It's found near ometic center. So aprepitant is an important drug, the first line in its class approved for the clinical use by the FDA. Superior for the preventing vomiting, but not nausea. Dose is 40 milligram, and half-life is around 40 hours. Aprepitant is rarely used for the post-operative nausea vomiting because of its relatively high cost. Newer receptor antagonist or these two drugs which will come to the market. Alvimupam also is a peripheral opioid antagonist, reduce nausea severity in the late post-operative period without affecting the central analgesic effect of the opioids. Alvimupam appears to work by decreasing post-operative ileus and opioid-induced bowel dysfunction. So propofol, the median plasma propofol concentration associated with the antiemetic response was 343 nanogram by ml, which is much more lower than the concentration ranges associated with GA, 3 to 6 microgram by ml, or sedation, 1 to 3 microgram by ml. Propofol in small doses, 20 milligram as needed, can be used for the rescue therapy. Total intravenous anesthesia should be used with propofol. In induction and maintenance, we have to use this propofol, and the side effects of the post-operative nausea vomiting will be less. Alpha-2 antagonists like clonidine and dexmedetomidine shows a significant but weak and short-lived anti-anesthesia effects. And also, clonidine is opioid sparing effect, has a opioid sparing effect. A small dose of midazolam 2 milligram when given 30 minutes before end of the surgery is effective in reducing of the post-operative nausea and vomiting. So also fluid supplementation, hypovolemia can trigger the releases of the methogenic arginine vasopressin from the posterior pituitary. Pituitary and crystalloid fluids have a same effects. Non-pharmacologic or acupuncture, neuromuscular stimulation of the median nerve, and other ginger root extract, hypnosis, suggestion, and homeopathy, giving hope, confidence in chew gums may be reduce the post-operative nausea vomiting. And also rescue treatment, early rescue treatment with 1 milligram of with the ondansetron seems to have a comparable efficacy and better effectiveness than 4 milligram of prophylactic ondansetron. After the administering an antiemetic, it's the most effective to choose an antiemetic of another class for the later rescue treatment. Repeating the same medication given for the post-operative nausea vomiting prophylaxis within the first 6 hours after the initial dose conferred no additional benefit. So the vomiting patient should be reassurance with a hope, correct vital sign appropriately, ensure adequate analgesia and hydration, look for the surgical cause like abdominal distension. If present, NG should applied and aspirate. Antiemetic should be repeated. Check prophylactic antiemetic was given or not. Antiemetic administration as a rescue should be from different class. So these are my references, and thank you from your kind attention.
Thank you so much, sir. Do we have any comments from the chairperson, sir? Dr. Rashid, there is a question. So,
Yes, please.
does any regional block works for PONV?
So for the treatment of the post-operative nausea and vomiting, there is no block because the cause it's a different multi-factor pathways or multifactorial, so not specific block.
Here's what I found.
Sir, there's a question from one of our delegates that what is more effective, giving a single shot of a drug or giving a combination therapy?
It's depend on the risk factors. If in a patient there are 2 or 3 risk factors, we divided in 3 categories. Is patient in its low risk, medium risk, or high risk. So the combination therapy is better than a single therapy in a medium and high-risk patients.
Okay, thank you so much, sir. There's another question that how would you try and stop a PONV in a young female patient?
I couldn't get your
So how would you
question.
try to stop a post-operative nausea vomiting in a young patient, a female patient who has experienced PONV previously also?
Yeah, so it's a history of the post has a history of post-operative nausea vomiting, and she's also female gender. So there is a
Yes, sir.
two risk factor present. So we have to give prophylactic anti-emetic drugs before as a rescue treatment for her, and definitely she will not suffer for the PONV.
Sir, there's a question. What about old drugs like Stemetil?
These much more drugs are using for the antiemetic. I couldn't take all of them. For example, like gabapentin, some other drugs. Stemetil is also used for the post-operative nausea vomiting in some cases.
Okay, thank you so much, sir. So do we
Welcome.
have any other questions? Neha?
Sir, there's a question. What regime do you follow in your institute, sir? The combination of anything or just one drug for surgeries, or depends on the surgery?
It's depend on the surgery. I will put a little bit here, some information. For example, the drugs should be selected due to which receptor is activated. For example, if we can say if the vomiting is due to 5-HT3 or 5-hydroxytryptamine serotonin release, like the source is vagos or chemoreceptor trigger zone. So ondansetron is the gold standard for the postoperative nausea vomiting. And if our patient is has a postoperative nausea vomiting due to chemoreceptor trigger zone triggering from the different sources, so then metoclopramide, droperidol, or promethazine will be better. If there is a motion sickness or postoperative nausea vomiting is from the vestibular stimulation or acetylcholine receptor activated, so here we have to give cyclazine or scopolamine both. Or if stimulation is coming from the cortical. In the second, if vestibular or NTS source is present or histamine receptors are suspected, so again cyclazine and diphenhydramine is the best. And if in a patient neurokinin receptors are activated and the patient is suspected for death, so then apropitant is important. So we have to decide on different, especially about dexamethasone. Dexamethasone will work on the NTS activity.
Thank you, sir. So we have another question. Antiemetic of choice in full stomach for emergency LSCS.
Antiemetic for the CS patient, here we can use metoclopramide and also cetralcar to reduce the acidity of the gastric. So these things we can apply.
Thank you, sir. Sir,
And
any
also we can use promethazine. So different classes.
Right, sir. Sir, is there a particular duration where at what time of the surgery to administer these drugs?
Every drug has a different half-life. So some drugs, for example, ondansetron, we have to give at the end of surgery. Some drugs we can use, for example, dexamethasone with a big half-life from the beginning of the surgery. So it depends on the drug half-life.
Right, sir. I guess no, any more questions from the audience we can have?
Yes, I'm Dr. Kausar from Bangladesh. Just I want to add one point to Dr. Rashid.
Yes, sir.
Any regional blocks, it works or not, the evidence is not there. But theoretically, I think it is possible because one is the vagus nerve and one is the glossopharyngeal nerves, which actually the apparent part, it comes from the stomach and upper GI. And it's a very important cause for the post-operative nausea and vomiting. It may work, and also the pharyngeal irritation also, which can be blocked by the glossopharyngeal nerve. So if you stop the afferent, so there is no stimulation of the vomiting center. So, but the chemical part, like that as a convey by the blood system actually, that hits the chemoreceptor trigger zone. This is not possible actually, but this pathway can be stopped, I think, if Rashid is agree. But yeah, because evidence,
about the glossopharyngeal nerve in vagus, I couldn't find something, but there is the controversial present some evidence. So you are right, sir. Yeah.
Thank you.
Thank you, Dr. Sardar. And does anyone has any experience with acupressure or acupuncture for post-operative nausea and vomiting? Okay. So we have Dr. Arian with us here. Sir, could you unmute yourself and give a few comments? Dr. Arian, could you unmute yourself, sir?
Hello. Hello.
Yes, sir. Yes, sir, you're audible, sir.
Sorry.
Okay, meanwhile, we have a question for you, Dr. Rashid. Dexamethasone injection, if it is given rapidly, it causes vomiting. What is your experience in this?
The injection should be slow, not rapidly in all patients, not only for the nausea and vomiting. Giving Dixa as a rapid injection, it is not allowed.
It is not. Thank you, sir. So, Neha, do we move on to the next session? If there are no more questions.
Can I make
yes, sir.
a couple of
Mr.
please?
Dr. Tajki Kahul has raised the hand.
Hello.
Yes, sir. Please, sir.
Can I go ahead? Can I go ahead?
Yes, sir. Please, sir.
Dr. Rashid has given an extensive review of PONV. PONV, in spite of the fact that it has a lot of work has been done on it, it still remains the most important problem or morbidity of a patient in the post-operative period. Besides the pharmacological methods, the non-pharmacological methods are also very, very important. If you take care of the patient by non-pharmacological methods, the dosage of the drugs and the incidence of PONV is reduced by 50%. There are innumerable publications about acupuncture and acupressure for decreasing the incidence of PONV. In addition, some very simple and basic points like a gentle suction, and while you are sucking the throat, making it sure that the tip of the suction catheter does not touch the posterior pharyngeal wall. You only remove the secretions and try to avoid the stimulation of the posterior pharyngeal wall or the nasal mucosa. The art and technique of suction is absolutely essential to reduce or abolish PON. Another very important point is shifting of the patient from the operation table to the trolley and then to the bed in the recovery or ICU. The shifting must be absolutely gentle. I would teach and advise my students that the shifting should be like shifting a rose from one place to another. Ensure that the rose petal does not fall. Because if you just slightly shake the rose, the petals start falling. That should not happen. The shifting of the patient from the operation table to the trolley and then to the bed has to be extremely gentle and in one go. These are some of the points which must be taken into consideration. And if you take care of these, the incidence is definitely going to come down absolutely. The era of post-operative nausea vomiting, when drugs like diethyl ether was used, has absolutely vanished. Because those drugs, those inhalation anesthetics would cause almost PONV in more than 75%. The drugs and the quality has improved. The incidence has to come down. But I would still stress the importance of non-pharmacological methods to reduce the pharmacological drugs by at least 50%. Thank you very much. The talk by Dr. Rashid was really very good. Very good.
Thank you so much, sir, for your pearls of wisdom. We are honored to have IAC President Dr. Devatya sir with us. Welcome, sir. And Naveen sir, would you like to add something to what has been said? I think there's some technical glitch. So, Neha, with your permission, do we move on to the next session?
Yes, absolutely, ma'am.
Yeah, I think
Yes, sir.
before Neha moves on to the second session, I must congratulate the speaker, Dr. Rashad, and from Afghanistan. And I'll invite Dr. Divetia, President ISA National, if he's there. Dr. Divetia, sir, if you can unmute and say a few words for today's session. Dr. Divetia, President ISA National, please.
Yeah, good evening. And again, congratulations and thank you for organizing this very nice series of webinars. We've had a very nice talk by Dr. Ahmed Akbari from Afghanistan on PONV, and some wonderful comments also by Dr. Tejkal. So, and now I think ISA is really very happy and delighted to be part of this Saarc grouping, and I congratulate Dr. Venkatgiri, Naveen Malhotra, and Virendra Sharma for organizing this and for all of us to take part. I think this is some education brings us all together, and I think the online format has shortened distances and allowed us to connect with each other. So I think it's a wonderful initiative, and I think I won't take much time, and we'll carry on with the academic program. Thank you.
Thank you, sir, for your kind word. Thank you. Over to you, Dr. Neha, for the next session.
Thank you, sir. Thank you, Dr. Rashid, for the wonderful and very extensive and very practical solutions by Dr. Kaul sir as well. So we had a great discussion. Moving on, I would like to, it gives me immense pleasure to call our chairperson from the land of happiness, that is Bhutan. So I welcome Dr. Jampal Sharing, sir. Sir is the HOD of Jigme Dorji Wangchuk National Referral Hospital in Thimphu, Bhutan since 2015. He has been teaching first aid to non-medical people in like school teachers, scouts, hoteliers, and tourist guides and UN workers. He has been teaching first aid to all the DESUP training people. He served as a member of National Search and Rescue Team. He's been the head of the Department of Anesthesia since 2014, actively involved in teaching anesthesia residency program, OT technician and other health professionals, and also actively involved in the development and teaching in Bhutan emergency life care support to all the doctors in the country. We welcome you, sir. And moving on to the speaker of today's session, Dr. Tashi Wangchuk. He has done his MBBS from Latin America School of Medicine in Cuba, has been cleared the Royal Civil Service Commission examination, and after MD, he underwent 1 year subspecialty training in regional anesthesia and acute pain medicine at Bangkok, Thailand, and he as a regional anesthesiologist, and he has been a faculty to KG University of Medical Sciences of Bhutan, and he's got 2 publications under his belt. We welcome Dr. Tashi. Dr. Tashi, handing over to you to please start with your presentation.
My presentation, please.
Yes, sir. Please.
Can I use my presentation, right?
Yes, sir. Please share your screen.
Yes, sir. Please share your screen, sir.
Sir, I'll request you to first open your PowerPoint presentation on the desktop and then share the screen.
Yes, sir.
So you can stop sharing it and then share again.
Oh, can I start?
Yes, sir, please.
Yes, sir.
So very good evening to all the participants, especially the president and also the secretary. For upfront, I would like to thank for giving me this opportunity, and also to my head of department, Dr. Jampel, for assigning me to present this topic, which is on role of regional anesthesia in the management of acute postoperative pain. So I have no conflict of interest in relation to this presentation. So the topic of the day, I would like to run through as a first part, the role of regional anesthesia in the management of acute postoperative pain. And the second part, I would like to share briefly the existing practices of regional anesthesia in the country. So these are the subtopics of my presentation: the regional anesthesia in extremity, in abdominal surgeries, obstetric and gynecology surgeries, and 1 or 2 slides of thoracic surgeries. So as you all know that we have come a long way in terms of managing the acute postoperative pain. We have started with very simple method, modality of pain, and now we have a very complex and reliable management of pain. And in all this, the regional blocks plays a very critical role. And this is being supported by this narrative review article and advances in regional anesthesia and acute pain management, which supports which says that the appreciation for the critical role that regional anesthesia can play in the multimodal analgesia, in-hand recovery after surgery, and also the procedure-specific post-operative pain management. So in upper limb surgery, as you all know that it is termed as a spinal of arm. And of course, we have other options, but the brachial plexus block is still the most popular one. And this article is on network meta-analysis of a different intervention, regional intervention that can be done on arthroscopic shoulder surgery. And this meta-analysis is based on randomized control trials. And these are some of the combinations that we have. And they try to find out which one is the best regional technique that we can provide for arthroscopic surgery. So in the post 12 hours after surgery, in this meta-analysis, they found that interscapular nerve block, when combined with suprascapular nerve block, is the best, is the best option as part of this meta-analysis. And both post 24 hours and 48 hours, the best combination is interascalar block and interarticular interarticular injection. So this is the prospect guideline on rotator cuff repair surgery, included 60 studies. So here too, they recommend interascalar block, either continuous or single shot interascalar block. And in this book, which is on acute pain management and scientific evidence, 5th edition, also supports continuous interascalar analgesia because it provides better analgesia, reduces the opiate-related adverse effect, and also improves the patient satisfaction. So in summary, we have that in the shoulder surgery, the block that is recommended is either continuous or single shot interascalar block. And similarly for arm and hand surgery, the brachial plexus block still is the most popular. And this article, which is a comparison between the general versus brachial plexus block in pain management, they found that brachial plexus block has lower pain score compared with GA. And this article, which is on regional anesthesia for athletes undergoing upper extremity procedure, they found that the regional block provides better analgesia, early mobilization, and improved rehabilitation, which is very important for athletes and also improves the patient satisfaction. And for hip surgery, we have these sets of regional anesthesia, but the most popular ones are fascial block and the pericapsular nerve group block. So I will, in the subsequent slides, I will talk on this. And this is an article which RCT trial tries to compare between the suprainguinal fascial block versus without no block. No? So they found that when the endpoint is morphine consumption, they found that the one who received fascial block has significantly lower consumption of opiates. And this article compares between the PNG block and the inguinal block. They found that the bank block has advantages over the lower incidence of cortex motor block at 6 hours time. And this article also further supports the advantage of the PNG block of having the lower incidence of motor block. And this is the prospect guideline of total hip arthroplasty, a systematic review and prospect recommendation. Here they have sets of recommendation and the intervention which are not recommended. So what they recommend is again the single shot, the fascia iliaca block. So in summary, as per this prospect guideline, these are the two techniques which are recommended: a single shot fascia iliaca block or single shot local infiltration. And the regional block in a knee surgery, we have these are the options that we have. However, adductor canal block is most popular. At least in my center, we do adductor canal block to all cases of arthroplastic, total knee replacement. And the review article on the prospect guideline, again, for pain management after total knee arthroplasty. So they recommend single shot adductor canal block combined with periarticular local infiltration analgesia intraoperatively. And this is to show, this article is on the advantage, whether do we have advantage of aiding IPAC to adductor canal block. So here what they have found is in the absence of local infiltration, aiding IPAC has no role. But however, if intraoperatively, if you do not give any periarticular injection, so addition of IPEC block with adductor canal block has advantage. So the role of intrathecal morphine in postoperative analgesia in primary total joint arthroplasty. This is another systematic review meta-analysis. They found that there is a less consumption, opiate consumption at 24 hours post-surgery if you give intrathecal morphine when compared with no intrathecal morphine. And also they found that there's no difference of PONV between intrathecal versus control. And of course, intrathecal morphine causes more incidence of pruritus. So this for upper abdominal surgery, these are the options that we have. However, the epidural anesthesia is considered as a gold standard regional anesthesia for all kinds of upper abdominal surgeries. And this is a systematic review meta-analysis that is done to find out the epidural anesthesia versus different analgesic regimen following esophageogastric resection. So they concluded that epidural is associated with reduced pulmonary complication and the pain after gastrectomy. And this is a prospect recommendation on the open liver resection. So they recommend thoracic epidural analgesia and subcostal TAP block. And for laparoscopic cholecystectomy, they recommend port site injection of local anesthetic, preferably long-acting local anesthetic. And for lower abdominal surgery, epidural analgesia may not be a better option because it can cause lower extremity motor block. And our main objective of first recovery may be defeated if we give epidural analgesia. So, however, we have other facial plan block. And this is a prospect recommendation for open inguinal hernia repair. So here they recommend TAP block, ilioinguinal iliohypogastric nerve block. And for prostatectomy, they recommend TAP block as a first choice for laparoscopy, both laparoscopic and robotic radical prostatectomy. And for TAP block for colorectal surgery, a meta-analysis, they have concluded that opiate requirement as well as the pain intensity at risk is better in TAP block versus not giving TAP block. So for the gynecology in obstetric surgeries, these are the options of regional block that we have. And for cesarean section, TAP block can provide effective analgesia after cesarean delivery with when intrathecal morphine has not been used. So for the cesarean section, though we have facial plan block like transversus abdominis plan block, however, intrathecal morphine is the first choice. So if patient did not receive intrathecal morphine, maybe TAP block may be the choice of regional anesthesia. And this is the prospect guideline on cesarean section. And the recommendation, the intrathecal morphine is the first choice, followed by epidural morphine. If the mode of anesthesia was epidurally, so epidural morphine can be given. And maybe as another choice, regional anesthesia will be local anesthetic infiltration or facial plan block, which is TAP block that I've discussed earlier. And for thoracic surgery, these are the options that we have in our center. Though we have one or two thoracic surgery, actually this is not it's not so popular. So in the prospect guideline for video-assisted thoracoscopic surgery, they recommend all three facial plan block: paravertebral block, erectus spinoplan block, and serratus antiplan block. And this systematic review and meta-analysis try to find out the analgesic efficacy of PAC2 block, and they compare with the systemic analgesia and also paravertebral block, and they found that PAC2 is better compared with systemic analgesia and perivertebral block in terms of 24 hours opiate consumption. And ESP block for breast surgery, they try to compare here a systematic review and meta-analysis, ESP versus no block, ESP versus thoracic perivertebral block, and ESP versus PAC2. So here too, the PAC2 seems to have a superior effect compared to ESP and perivertebral block. So this is a narrative review on regional anesthesia and acute perioperative pain management in thoracic surgery. So here they tried to find out in the procedure like thoracotomy and thoracoscopy, what regional blocks are recommended. So here for thoracotomy, total, thoracic epidural analgesia and PV perivertebral block can be used. And for thoracoscopy, perivertebral block is recommended. So in summary, the take-home message that you may have from a presentation is for shoulder surgery, ISP single shot or continuous can be given. For arm and hand, all approaches of brachial plexus can be given. For hip, either fascia iliaca block or pericapsular nerve group block can be given, depending on whether you want, whether the motor block is concerned or not. If you think that motor block is a concern, maybe a PNG block is preferred over fascia iliaca. For knee surgery, SCB with LIA or IPEC block. And for abdominal surgery, epidural is the gold standard. Or you can also give subcostal tap block. For lower extremity, epidural may be not a good choice, like I said, because of it causes lower extremity motor block. So ilioinguinal, iliohypogastric, and tap block. For cesarean, OBGYN, the first choice is spinal morphine, 50 to 100 microgram of morphine. And if you wanted some facial plain block, maybe tap block can be given. For thoracic surgery, thoracotomy, TA, and PVV, and for thoracoscopy, perivertebral block is preferred. So my second present, because I have enough time, I would like to share some of the existing practice of regional block in my country. So my country, as you all know, a very small population of little less than 700,000. We have 3 regional hospitals to the center and to the east, and 1 in the capital. And we have 17 district hospitals. And this the cross sign is where our hospital is spread throughout our country. And we have around 11 hospitals which has both surgical and anesthetic facilities. So where regional block is given. And we have 18 anesthesiologists, and we have 27 nurse anesthetists. So our backbone of our anesthesia service is still nurse anesthetists. We have ultrasound and nerve stimulator. Also, we have fewer patient control energy emission. And these are the number of blocks that were done in 2021 and 2022. And definitely in 2023 and 24, definitely we'll have higher number of patients receiving regional block. And by department, orthopedic is the one which has highest number of patients receiving the nerve block. And the challenge, the challenge that we have while providing the post-operative pain is we still do not have injectable and oral form of COX-2 selective inhibitors. And we are still in the process of negotiating with the procurement section to at least have 1 injectable and 1 oral. And when you have it, I think we'll have a holistic, and we'll have, we can give maybe highest standard of acute postoperative pain in future. So thank you so much. This is my last slide. And before I conclude, I'd like to share, I'd like to take maybe a few seconds and to share that this is not a part of my scientific presentation. However, I would like to take this opportunity to share that our country has announced a small change in the tourism, where if you want to conduct a scientific meeting in our country and also visit our country, the Royal Government of Bhutan offers a waiver for meeting, scientific meeting. So in future, if you have any such plan, you are all welcome, and do let us know. So thank you so much once more for having having me this opportunity, and thank you, and Tashidele.
Thank you, Dr. Tashi Wangchuk. That was very comprehensive and very nicely presented, considering the whole part of the body and the regional anesthesia techniques commonly used. So I would now like to invite Dr. Shering for his view, for his comments. Dr. Jampal Shering, sir, can we please have you? I think. So in the meanwhile, we can take some questions. So we have a question from Dr. Umesh. Is there any experience about comparison between Peng block and fascia iliaca block in hip surgeries?
Thank you for the question. Yes, I had one or two slides trying to compare between the Peng block versus suprainguinal fascia iliaca block. So in terms of post-operative pain, there's no difference, but Peng block seems to have advantage over lower incidence of motor block. So if your concern is of recovery and you do not want to block the motor part, maybe the Peng block is preferred over suprainguinal fascia iliaca block.
Right, sir. And so we have another question. Comparison of morphine, pethidine, buprenorphine, or fentanyl in intrathecal injection, if you have any experience with that.
I've experienced with two opiates that we use. One is fentanyl and one is morphine. The side effect profiles are similar, except that fentanyl has a shorter action and morphine has a longer action. Otherwise, all PONV, the pruritus, sedation, and other side effects, the profile is same.
Okay, sir. And sir, there's another question about sacral plexus block for intraoperative analgesia in patients undergoing hip replacement surgery. So, so they want to know that if you have any experience with bupivacaine in sacral plexus blocks and how much volume and concentration is used.
Sacral plexus block, I'm afraid that I have not done because we have other options which has is less invasive and which work perfect. So sacral plexus is one is very deeper. You have to go into a deeper structure, and definitely you need more skill. And so I would say that I have done other blocks which can actually equally have a same role. So I don't have, maybe I don't know, other colleagues. And
Any comments do we have from the audience? Professor Naveen, sir? In the meanwhile, Dr. Jambal Sharing sir has some issue with his microphone, I think. So he has replied on the chat box that while using fentanyl and morphine in intrathecal injections, he says that both have been, you guys use both of them, but pruritus has been an issue. Dr. Parul ma'am, any more
have-
questions?
I think, Neha, we have so many experienced, learned senior people with us. Maybe they can help with this issue of fentanyl. In my center, we give around dexamethasone 4 milligrams around 15 to 20 minutes before we administer intrathecal morphine or fentanyl. So far, we've not experienced any problem of pruritus. But I think any senior person who's here can help us out with this.
I also use fentanyl, but I have not seen any pruritus. But the action is not very long. It is around 4 to 5 hours from the time of giving the intrathecal 25 max. If you give that, it's not. Maybe the transition period from the surgery to that's the only thing. Not very long. Actually, it's very short. That's what we saw. Instead, if dexmedetomidine used, it takes for about 8 hours. The staffs are very happy if it is given intrathecal post, especially hysterectomy patients. They are very, very comfortable with the dexmedetomidine than fentanyl. They say that patient is very comfortable for 8 hours. The transition slowly they go back to the normal. That's right.
So what dose of
Yes,
dexmedetomidine commonly is used?
sorry.
10 mics.
10 mics. Okay, sir.
Regarding fentanyl or buprenorphine. Hello.
Yes, sir.
Venkatgiri,
You're audible,
can you
sir.
hear?
No, we can hear you, sir. We
Yeah.
can hear you.
This is Dr. Bande. Yeah. So with fentanyl and buprenorphine, which we used extensively epidurally, buprenorphine, I'm saying, intrathecally, people are obviously using fentanyl more and dexmedetomidine. But we have seen occasional pruritus, these reactions once in a while. The problem is it is not predictable as to who's going to get it. So we know if it is very severe, then obviously we have a symptomatic treatment. But once in a while, you do see them. Now, we do not know exact mechanism, whether patient is extra hypersensitive to one particular group of drugs. It's very unpredictable as to who will get it. So, don't have
Right.
clear.
So
So
there's
any
a
role of
question.
remifentanil? I think some technical glitch.
Dr. Wangchuk, there's a question for you. Is remifentanil also used? Kindly
We don't
unmute
have,
yourself.
right now we don't have remifentanil in our country. And even the place where I was trained in Chulalongkorn Memorial Hospital, they don't have remifentanil. So I don't have experience on that.
So there's another question. Any peripheral nerve blocks or intraoperative analgesia for hip surgeries?
For what surgery, madam?
Hip surgeries.
Hip surgery. So for hip surgery, like I said, the most common and most commonly practiced is the suprainguinal fascial LECA block. Of course, we have two varieties of fascial LECA. One is supra and infrainguinal block. The infra looks like we are going little bit. This has more motor block and it is quite close to the femoral nerve. So whereas suprainguinal, we have that advantages. And we have PNG nerve block, which is pericapsular nerve group block, which is quite new. So they found that PNG block, has a lower incidence of postoperative motor block.
Right, sir.
And of course, we can give a selective femoral nerve block with, of course, a disadvantage of having motor block. So these are some of the options we have.
So, Dr. Umesh is commenting on remifentanil, and they're saying that in high-risk patients where we intend faster recovery, remifentanil is better. They use remifentanil in their center. So also, what is the efficacy of morphine as compared to newer opioids? in
Efficacy of
intrathecal injections?
question, madam?
Sir, the efficacy of morphine as compared to newer opioids like fentanyl in intrathecal injections.
For the intrathecal, like I said, because you have other intrathecal morphine, as per the research, is recommended for, like I said, the prospect guideline. It shows that intrathecal morphine is as a first choice for cesarean section, but not for other extremity, because extremities we have other regional block which provides a better profile. So intrathecal morphine 50 to 100 mics is the first choice for cesarean section, but maybe not for other surgeries.
All right, sir. I think that's all in the chat box we have. Any more questions? I think we're done. Dr. Parul ma'am, anything else from your side?
So far, we haven't had any more questions, but excellent presentation from both the speakers. So, may we have Naveen sir to say to conclude or say something?
No, it was a presentation from both the speakers were very good. I think we are on time also, so better invite Dr. Virendra Sharma for vote of thanks.
So, I would now like to invite Dr. Virendra Sharma sir for his vote of thanks.
Thank you, Dr. Parul. Good evening.
Sir is the treasurer for Saarc AA, consultant anesthesiologist at Vivekananda Polyclinic Institute of Medical Sciences, and past Lucknow treasurer, past treasurer of ISA Lucknow branch. Welcome you, sir.
ISA National.
ISA National.
Thank you, Dr. Parul. Good evening, President Saarc Association, Dr. Venkatgiri, Secretary, Dr. Naveen, other executive members of the Saarc Association. I'm happy to note that with the subsequent progression of these webinars, today I can see almost representation from all the constituent society of Saarc. Some are becoming very regular, and I think it will go in a long way in future. And the happiest thing is today we could hear talks from our members from Bhutan and Afghanistan. So that's a very pleasing note, and I'm sure in the coming time, all those who are attending regularly, more and more will join us, and that is the basic purpose of having the webinars as well as interaction among ourselves, sharing our practices. So I thank Dr. Nurul Aryan, President of Afghanistan Society, Dr. Hamidullah, the speaker, eminent speaker, Dr. Ahmed, then from Bhutan, Dr. Jempil, then our speaker, Dr. Tashi. Both of them represented very well. And I'm sure these webinars in coming time will give us more opportunity to interact, and we may see all of us together in the upcoming Saarc Association. Knowing each other, knowing our views, definitely it's going to increase more coherence among us, and that will be the best advantage of having our association. So thank you so much for joining, and hope to see, as Dr. Naveen has already announced the next date. I must appreciate the efforts of Dr. Naveen. One and one, he has almost involved all the associations of Saarc. And hats off to you, your consistent hard work. And today itself, you have declared the next date. Congratulations, Dr. Naveen, for your hard work. You deserve it. And thank you to all. Thank you.
Thank you all. Good night. Good night.
Good night, sir.
Thank you all.